Good day, everyone. My name is Jerry McKee. I'm a board-certified psychiatric pharmacist and certified mental health first aid instructor. And today we're going to be talking about effective communications in persons with serious and persistent mental illness in the pharmacy settings. And a lot of this material is excerpted from the mental health first aid training that you can do if you choose after the presentation is completed today. And I will instruct you at the close of today's presentation regarding how to access mental health first aid training opportunities in your local community. So our objectives today are to first and foremost, the objectives are to we have four of them. Gain an appreciation for the opportunity to positively impact individuals living with mental illness, their families, and their healthcare providers by improving your communication skills. And basically, it's improving your comfort and confidence in interacting with this population, because the communication skills are the same. Understand the importance of building mental health literacy in your practice setting, because there are so many patients that with mental illness and substance use disorder in your population. You may not even be aware of it. And you want to take any opportunity you can to minimize inadvertent stigma that might perpetuate practices and marginalize these individuals, and to gain a better understanding and respond to signs that they may be decompensating, and be able to intervene appropriately. You certainly want to be aware of the negative impact of stigma for those persons who are living with mental illness and substance use disorders in your community and in your pharmacy's population. And then recognize that mental health first aid is just one of many training opportunities that are evidence-based that can begin to a process of relearning how we communicate effectively to bend the curve in terms of minimizing stigma associated with mental illness. So first, we'll start with what is a mental disorder. It is a diagnosable disorder that affects a person's excuse me, thinking, feeling, and behavior. And further, it's not just a disorder that is characterized by having a bad day or a bad weekend, a bad series of days. It's longitudinal to the point that it impacts an individual's ability to perform their work activities, to be an effective family member, be an effective citizen. And so it negatively impacts their ability to engage in satisfying relationships. So it impacts their quality of life. Mental health problems are common, and we'll talk about some prevalent statistics here in a couple of slides. And then stigma is associated with mental health problems and can often lead to other downstream healthcare related concerns. We'll dive into that as well. Many people are not well informed about what mental illness actually is, and that is it is in fact a biological disease, and that is often the root cause, and this misunderstanding is often the root cause of stigma. Psychiatric professional help is not always available, and with stigma superimposed and directed at persons with mental illness and substance use disorder, that can also lead to people not pursuing the psychiatric providers that may be available in their community. So there's oftentimes gaps in care. We'll talk about that. And many people, including pharmacists, nurses, primary care physicians, don't have a great level of comfort and confidence in knowing how to interact with persons with mental illness and substance use disorder, because you don't get a lot of this interaction with this population in your training, because there's so much to cram in to your didactic and clinical training that oftentimes mental illness and substance use disorder, unless you have a specific interest and take electives in that area, you may have just a very limited exposure to these populations. So lastly, people with mental health problems often don't seek help for a variety of reasons, including stigma and self-stigma and an associated lack of self-worth. They hear and feel and experience this stigma so frequently that they begin to buy into it and believe that they don't have the same, they don't have should not have rights to the same access to care and the same opportunities as people without these kinds of disorders. So let's back up just a minute and define what are we talking about actually when we talk about stigma. If you remember Nathaniel Hawthorne's Scarlet Letter, stigma is a form of the Scarlet Letter. It can be seen or characterized as a mark of shame, disgrace, or disapproval, which results in an individual being shunned or rejected by others. I mean, that's kind of the long and short of it. Stigma is associated with a variety of issues, but in particular, mental illness and substance use disorder. And it can be very strong, in particular, persons with schizophrenia, bipolar disorder, and substance use disorder. And the level of stigma in general tends to be associated with the degree that their behavior differs from that perceived as quote unquote normal. So that as the individual's behavior is less further away from the standard begins to be seen as further and further away from two standard deviations of what we see as normal, then there's more and more stigma attached. And so because of stigma, people who are dealing with a mental illness are often marginalized and rejected by friends, relatives, neighbors, and employers. And that can lead to aggravated feelings of rejection, loneliness, and depression. And understand that social withdrawal can be a key characteristic of mental illness just as part of the disease states. And when you further superimpose stigma, that can really worsen the social withdrawal and really cause the disease state to be worsened, can lead to even suicidal thoughts and behaviors. So it's very, very critical. But at minimum, it leads to feelings of lack of self-worth and often lack of pursuing care, because they just don't care to get out into the community because they're concerned about the social rejection that they feel is palpable. And they also feel that they're denied equal participation in their family life. Typical social networks they don't feel like those are open to them. Productive employment may not be open to them because they can feel that others just aren't comfortable interacting with them, and they can feel perhaps you and your employees in your pharmacy may not be comfortable interacting with them. And so that's one of the purposes of today's program is to learn how to interact, how to talk with persons with mental illness, and listen non-judgmentally, and help them feel comfortable. And it can be a very valuable tool to both you and to the people that you're serving. And as I've kind of alluded to, and you can kind of put this together, that stigma, of course, has a negative impact on a mentally ill person's ability to live a good, full life and find their pathway to recovery. And the isolation and humiliation is a negative factor on their road to recovery. But primarily, the foundation of most stigma is this third bullet here: the myths, misconceptions, and negative stereotypes about mental illness held by many people in the community, including people, trained healthcare providers, and these tend to be perpetuated. We don't typically stigmatize persons with diabetes, hypertension, and until we begin to see universally persons who are dealing with mental illness as someone dealing with a biological disorder, as a society, stigma will be perpetuated. So we've got to begin to make inroads into stigma one person at a time. And I've always seen it as when I train pharmacy students, PharmD residents, psychiatry residents, any sort of trainee, nursing students that I've taught. one student at a time. And there any number of studies have shown that stigma begins to be impacted positively when trainees have some sort of clinical exposure to persons with mental illness and substance use disorder in their training curriculum. So because they begin to see that these people are humans just like we are. They're more like us than different, and they just gain a level of comfort in learning how to deal with these people as individuals, as I did as a young trainee. And certainly I had some reticence initially, but like anything else, it's a learned behavior. You learn how to interact effectively with all populations. Uh, so one last thing is the just to reemphasize the self stigma, where as I mentioned earlier, the individual has felt this mark of shame, this stigma so frequently that they begin to buy into it, and they internalize this belief and believe that they uh, uh, aren't worthy the same quality of care, the same benefits that other citizens have. And it really makes it hard for them to seek access to care, to get out of their shell and to get out into society and enjoy a good quality of life. And it really, as I said earlier, it really is an impediment on their way to full recovery. So with that kind of foundation about stigma and how it can negatively impact persons with mental illness and substance use disorder, we're going to talk about prevalence, and then we're going to move on to talk about what you can do in your day-to-day practice to more effectively interact with persons with mental illness and substance use disorders, so that you don't perpetuate that stigma and you can make them feel welcome in your pharmacy. A few notes about the prevalence of mental illness in the United States. This is from NAMI, the National Alliance on Mental Illness, which is the flagship organization for persons and their families who are dealing with mental illness. Almost 50 million adults experience mental illness in a given year. That's approximately 1 in 5 Americans, and so I mean that's pretty impressive. That's 20% of all Americans will experience a mental illness at some point in the lifetime. The the prevalence by diagnosis, you see the things like schizophrenia and bipolar disorder are lower frequency, but typically higher intensity kinds of illnesses. Depression and anxiety are higher prevalence, but typically lower intensity. And not to minimize the impact of those disorders, but uh, they are don't as frequently lead to the inpatient hospitalizations and decrements in the ability to hold a job and do some of the other things in terms of being able to lead a well-rounded good quality of life that an exacerbation of schizophrenia and bipolar disorder might do. Uh, However, all of these can be very debilitating and can lead to some significant quality of life implications. One thing I did want to call to your attention uh, is that the relationship of suicide to mental illness and substance use disorder. Obviously, suicide is highly correlated with depression and schizophrenia and bipolar disorder, but also to a lesser extent with anxiety. 90% of persons who die by suicide in the United States do have an underlying mental illness. Suicide is the 10th leading cause of death in the United States, and among uh, the younger population cohort, 14 to 24, it is the second leading cause of death. So it is definitely a significant issue in younger age population, and also in those 65 and older. It is one of the leading causes of death in older Americans as well. Alcohol use disorder is prevalent, as you can see here, somewhere between 4 to 8%, depending on the race and ethnicity. And illicit drug use, age 12 or older, higher frequency, somewhere between 13 and 25 to 35%, depending on the race and ethnicity. So you can see all of these disorders are fairly prevalent, and it's nothing we should be comfortable in dealing with persons who are coping with or trying to cope with these disorders, just as we are with persons with diabetes, hypertension, or cancer. Uh, so typically, a lot of the disorders are, fly under the radar until there's an exacerbation or a mental health challenge. So by definition, what is a mental health challenge? That is when there's a major change in a person's ability for their thinking, feeling, or the way they act, their behavioral manifestations, and to the point that it interferes with their ability to live their life and go on about their daily activities. Um, and in general, again, we're not talking about a bad day or a bad couple of days. It may last for weeks, months, and does not resolve spontaneously or in a few days like we would anticipate it doing. So what we're going to talk about are what are some key early signs and symptoms that you can hone in on when individuals that come into your pharmacy, and they're dealing with a mental illness, or they have a mental illness diagnosis, they're getting medications, and typically they're doing well. But what are some of the things you should be aware of so that you can appreciate when there are changes from their best baseline behavior that maybe you should help them by asking questions about their status in a confidential setting, to maybe help them get access to care before they totally decompensate. So we'll talk about early signs and symptoms and worsening, and what would manifest or what would qualify as a full-blown crisis. And I think those are the kinds of things that are important, because if you think about it, most patients are in their primary care doc's office or their psychiatrist's office 2-3 times a year, maybe four at best. They're in their pharmacy once, twice, maybe 3 times a month. And so you have the opportunity to see them much more frequently, and can perhaps detect early signs and symptoms of decompensation. And if not you, your intake clerks, all these people can be trained to pick up on early or emerging signs and symptoms of decompensation. Mental health first aid was actually initially developed to train lay people to deal more effectively with persons with a mental health crisis. So you don't have to be a trained clinician in order to use this skill set. So anybody in your pharmacy can be taught to pick up on these signs and symptoms, and to have a conversation, or refer the person, if they're not comfortable, refer the person to you as the pharmacist to have that conversation in a confidential area with the individual, and help them get access to care and supports that they need. So multiple risk factors for uh, uh, mental health and substance use challenges and decompensation. Uh, I've always said that, and the experts will back me up here, that mental illness and substance use disorder doesn't discriminate in terms of socioeconomic status. However, if you are in poverty, don't have a job, and you're focusing on Maslow's hierarchy of needs, meaning food, water, and shelter, because you don't have a job, your mental illness has not allowed you to have full-time employment, and you don't have a steady stream of income. That is a significant risk factor for uh, for decompensation. Whereas if even if you have that same mental illness, but you have family supports, even if you don't have a job, if you have family supports and your finances are covered by a supportive family, uh, or you have a disability income stream or some methods of paying the bills, then you're much more in line to have a better outcome longitudinally and to get in recovery and stay in recovery, as opposed to persons who are having difficulty dealing with the day-to-day stressors of life. You know, so that supportive family and avoiding those kinds of life stressors are absolutely critical. And of course, the more chronic medical disorders you layer on top of a psychiatric disorder, the more at risk you are for ongoing decompensations of your mental illness. And these are fairly intuitive, uh, but the family history and the financial supports are just absolutely paramount and most critical. Uh, Another thing, and this kind of goes along with the stigma, but also is part and parcel with part of the mental illness disorders and some low level paranoia, is a mistrust in the healthcare system. Just kind of a guarded approach to healthcare, and you know your own in your own personal experience likely that you've had negative experiences with the healthcare system as a well educated professional. Uh, and so you even with your great education, you understand the difficulty in navigating the system, and when you have a uh, a negative situation with the healthcare system, you know, you you get up off the floor and brush yourself off, and you keep going. But if you can see, if those episodes are repeated, you would begin to think the system is directed at specifically at me, and they're focusing on me, and it's part of the paranoia, and it's just an ongoing effort to focus on me as an individual. So it just perpetuates that lack of access and care, and it drives them away from the healthcare system. So you can see it just continues to cause problems with individuals not accessing the healthcare system as they should in order to maximize or optimize their outcomes. So the gaps in treatment are absolutely deplorable, but it is part of the problem in not only mental health care, but in physical health care as well. More than 40% of people with mental disorders sought no treatment in the prior year, and this has been an ongoing problem. Part of that is the lack of trust with the healthcare system, and another part of it is lack of psychiatric providers. There's a significant gap across the entire United States in the availability of psychiatric care providers, and in particular, it's worse in rural areas than in more urban and suburban areas. And North Carolina is in large measure a rural state, so that is a problem, in particular here in North Carolina. These barriers, of course, are going to vary depending on the community. As I said, the more urban communities it's less of an issue. The more rural areas, it's more of an issue. And then there are unique circumstances in every community. But another compelling factor is that for so long, the physical healthcare system and the mental health care and substance use disorder treatment systems were so uh, compartmentalized, so siloed that one system didn't know anything about the other. So uh, referrals back and forth were difficult. And so if a person, let's say, sought treatment with their primary care physician for what turned out to be bipolar disorder, uh, oftentimes the primary care community didn't have a good feel for what the local resources were for treating uh, the psychiatric care resources for treating bipolar disorder. Those were so disconnected. That has really improved in the last decade. However, we still are suffering from a lack of psychiatric care providers. It continues to be a problem, however, in particular with finding providers who are willing to treat substance use disorder. That continues to be an ongoing problem in particular. So the primary barriers are cost. A lot of these individuals with chronic mental illness and substance use disorder don't have insurance. The stigma that we talked about, logistics, rural areas, lack of access to care, and then awareness of how do I navigate the system? Who can help me navigate this system? So shifting gears just a bit, we'll talk about what are the things that you as a practicing pharmacist might be looking for that might suggest that an individual might be beginning to decompensate, and we're talking about changes from their best baseline behavior. If these kinds of things that we're going to talk about are part and parcel of who this individual is on their best day, then it's probably nothing to be alarmed about. But things like for a person who's typically well put together, and even if their clothes are old and worn, if their clothes are clean and pressed, but suddenly they show up and their clothes are dirty and wrinkled, they don't. The individual may look like they just rolled out of bed and they haven't had a shower. They may have body odor because of lack of good personal hygiene, having difficulty focusing, whereas typically they're spot on and they can hold up their end of a conversation. They seem distracted. All of these kinds of things might suggest that something is going on. Again, if that's not their typical behavior, if they're in their conversation that they're having with you or one of your personnel in your pharmacy suggests that their life's just not the same as it was a short time ago. They're not enjoying things. They may make comments about uh, I'm not sleeping well. I'm not eating well. I'm just not enjoying things I used to enjoy. I used to like to go to the movies. I used to like to go to the park. If, maybe your clerk says, "Hey, Mr. Smith, how's your dog Bingo?" And he said, "Well, I had to give Bingo away because I couldn't care for him anymore." Those kinds of things might be a tip off that something is going on, and you may want to pull the individual back and sit him down and ask him, what's going on. Yeah, and something as simple as saying, "Man, I'm concerned about you. You've been coming in our pharmacy for years, and suddenly you don't seem to be the same, and I'm just really concerned. Is there something you want to talk about? What can we do to help you?" Uh, they may or may not be willing to talk with you, but it's good for the individual to learn that somebody out there cares about them and is willing to talk with them. That simple gesture can make the difference in someone who is beginning to have suicidal thoughts. That might make the difference in them continuing down that path, and then in making an alternate, selecting an alternate pathway. That that act of caring and opening the conversational door may be all that's needed for them to open the proverbial book, to really have a talking catharsis and talk about some things that they needed to get off their chest, so to speak. And we'll talk about listening non-judgmentally in just a few moments. But it's critically important that if you notice these kinds of things, that if you're not the one to have the intervention and have the conversation and get them connected to care, that somebody is having that conversation with them. Just like with an infectious disease or a cancer, uh, early identification and aggressive interaction is critically important to having the best outcome. Without early intervention, early identification, and intervention, it can lead to things like job losses, school dropouts, relationship deterioration, problems with the authorities, self-medication with things that you aren't ideal, like drugs and alcohol. So uh, not that every case is going to go down any of these paths, but unfortunately, this becomes very predictable. Untreated mental illness can lead down these pathways. Job losses, relationship breakups. There are two things. One that commonly characterizes what we're talking about here. One is absenteeism, where people just don't show up to work or they don't show up to relationships. The other is presenteeism, where they show up, but they're not functional. They can't make decisions. They're not productive. It's the lights are on, but nobody's home kind of situation. So that's really important that if someone is in those kinds of situations that they get help and get help sooner. The sooner the better. Um, because as I said, delaying treatment simply just worsens outcomes. Like if you have a pneumonia, you know, you need to get that antibiotic started just as quickly as possible. The longer the delay, the more difficult recovery can be. And the fact of the matter is, uh, people are more likely to seek help if someone close to them recognizes the problem, has a candid conversation with them, and holds their hand, so to speak, and walks them through to get the help that they needed. Sometimes that reflection of an individual's behavior from someone else can be the impetus that they needed to reflect, because they may be having some self-doubts about, I'm not feeling they may have thoughts like I'm not feeling well, and I think I have a problem, but I'm just not sure. Maybe I'll snap out of it, the old snap out of it mantra. But when they hear someone else who they know well and respect reflect back on them that, hey, Joe, I'm worried about you. Things don't seem to be going well. How can I help you? That may be the that may be the shove they needed to overcome that inertia to go ahead and get the help that they needed. So how do you have that conversation? Because it is a difficult conversation if it's not something that you've practiced for 40 plus years like I have. But you have to be careful, because words matter, and words can hurt if you're not careful in how you select them. So we use something, you've probably heard of this, called person first language, where we don't label the person by the disease. For example, we don't uh, call a cancer person who's dealing with cancer, we don't call them a cancer patient. It's a person who has cancer. Similarly, a person with schizophrenia, we don't refer to them as a schizophrenic. We refer to them as a person who is living with schizophrenia, a person who is experiencing a mental health challenge with a thought disorder, or a person living with depression, a person diagnosed with anxiety, those kinds of things. And further, uh, there is a gentleman named Dr. David Sussman, who's a psychologist. I found this on the internet many years ago when I was teaching a doctor of pharmacy class on how to effectively interact with persons with mental illness. I found this 10 commandments for how to talk about mental health, and it's really succinctly characterizes some breadcrumbs that you need to carry around with you. And this starts with using person first language. Mary has schizophrenia, not Mary is schizophrenic. Don't use pejorative terms like uh, uh, mentally handicapped, mentally disabled, those kinds of things. Use the appropriate diagnosis. Or if the patient tells you how they want to be characterized, then go with that. Even if it's wrong, go with that, because the person trumps everything. If they prefer to be uh, referred to as mentally handicapped, then that's by George who they are. Uh, but the pejorative terms are really important. Things that have fallen out of favor, and that once may have been totally relevant and useful clinical terms, like mentally retarded, uh, things of that nature, are you need to put them on the back burner and go with what's currently accepted uh, characterizations, such as no longer using mentally retarded and going with intellectually and developmentally disabled. The trash can terms that are pejorative, such as crazy, insane, a couple of bricks shy of a load, all the kinds of characterizations that you used in middle school, you know, do your best to avoid those. Those are just uh, inappropriate and they don't serve any positive purpose. Use the appropriate clinical diagnosis with person first language, and further, in particular with persons with substance use disorder, they're not addicts, drunks, junkies. They're people with substance use disorder. And another thing, skipping on to number 7 here, when a person tries to take their own life, we need to be careful about how we describe that. Using the term committed suicide, uh, or saying that a suicide was failed or was successful, there's nothing. Well, actually, a failed suicide would be a successful suicide if you think about it in those terms. But using fail and success around suicide is just really inappropriate. What you should try to reframe your thoughts and your verbalizations is to say that someone died by suicide, or they took their own life, or they had a suicide attempt, and uh, another way that just drives me to distraction is when you hear, in particular, when someone who is like an actor or a musician or artist or something, and they die by suicide. Uh, the news media will say something weird like, well, they've suffered with demons for years, and they finally committed suicide, which is, a double whammy, because they use the wrong characterization of suicide by saying committed, and then they characterized depression or substance use disorder as demons. Well, when somebody dies from complications of diabetes, you never hear the news media get on TV and say, "Well, this this well-known actor died from the demons of eating too many Dunkin' Donuts, and their A1C was in double digits, and their doctor told them time and time again that they were going to have to reform, or it was going to be curtains." They don't do that. So why not treat persons with mental illness and substance use disorder with the same courtesy, right? So mental illness and substance use disorder are biological diseases. Let's call them by their clinical diagnosis. Treat the persons who have these disorders with the same courtesy that we do with persons who have diabetes and hypertension. You've heard me say this before. I mean it. It's true. Words matter. Uh, so, and again, I refer you back to number 10. Irrespective of all that I've told you about the 10 commandments here, if the patient tells you that they they prefer to be characterized by however they call their condition, then that's what you go with. That's what they're comfortable with, and just go with that. So, um, and one other thing, number 9 here, in our day-to-day conversation, we tend to minimize mental illness in a lot of ways by saying, when you're having a bad day, I'm so depressed, or I'm OCD, or whatever. And that really does minimize the significance of the clinical disorder. So you need to keep those things in mind. And this is a work in progress. This psychiatry has been my life's work, and I still catch myself erring on the side of making these mistakes. But just be mindful and try to reframe yourself as best you can, and move in that direction, and try to help those around you do the same, because as I said, words matter. uh, and in dealing with individuals with mental illness conversationally, things to think about are, in your conversation, is listening non-judgmentally, and things to avoid: not telling the person to snap out of it, don't act hostile or sarcastic, don't blame the person for the symptoms, but we don't blame persons with diabetes because they fell off the wagon and ate a donut. So if someone with substance use disorder fell off the wagon and relapsed, and had a weekend where they relapsed, well, you help them, brush themselves off, get back on the wagon. That's what we do. Uh, nagging never works. It doesn't work personally. It doesn't work professionally. Uh, don't trivialize the person's experiences. Whatever they're telling you, you have to accept it, that's real to them. That's what their experiences. That's what their experiencing is, and so that's really important. Uh, and as far as trying to cure the person, don't offer advice. Offer evidence-based hope, like getting them connected to care. Where you are not a psychiatrist, I'm not a psychiatrist, but people that can who are trained and are in a position to offer that kind of help. So that's our role. So that's really important. And speak with the person uh, as if they were on the same intellectual uh, platform as you are, and person to person, adult to adult. No patronizing, because that's important, because people can feel when they're being talked down to, and that's not, I mean, that's part of stigma. But and as I say, many times, words matter. We also have to think about the cultural considerations. Not everybody was reared in the same culture and traditions that you and I were, because you and I weren't raised in the same households and cultural traditions. So everybody's experience difference. Has been different, and we are, in fact, the sum of all of our life experiences. So keep that in mind. Don't make assumptions. Uh, for example, some people um, are from the John Wayne school of thought. They like eye contact. They like a hearty handshake. Other cultures do not like if they feel that it's disrespectful if you make eye contact. They do not want to be touched. So just be mindful of those kinds of things. Uh, and understand too that when you suggest that someone might need to get help from a professional, some cultures don't really endorse Western medicine's uh, uh, psychiatric care system. So they seek support and care through their religious and community elders. So uh, but you have to work with what you're given. So just be prepared for that. And you have to set aside your own beliefs and listen non-judgmentally. Try to understand the person and find out where they are, meet them where they are, and help them to access the care that they can access. Uh, because expressing criticism and negative beliefs about their situation can further perpetuate stigma and their reticence to seek care. But when it gets down to it, um, when the rubber hits the road, so to speak, you got to say, okay, we've had this conversation. How can I support you? Tell me what you need. You got to tell me what you need. How can I help you? I can help you get connected to care. I can give you phone numbers. I can make the phone call with you, but you got to tell me what you think you need after we've had all this conversation. Uh, you can ask them about things that have worked in the past. Um, Encourage them to take care of themselves. Ultimately, it has to be a shared responsibility, with most of the responsibility taken by the individual themselves. Uh, and you can certainly, you're always on a sound footing when you discourage the person from seeking and utilizing negative coping strategies like drug and alcohol use as a coping strategy. That's never a good either short-term or long-term solution. But absolutely, if you feel like the individual needs professional help, encourage them to get it. help them find someone in a directory, or if you have colleagues who can offer that help, help them make that call. Some of the kinds of things that we talked about that you might notice. This is just an extension of the things you might notice that might trigger a conversation. Things that behaviors that signs and symptoms that might be a cue that things are starting to unravel. We talked about the hygiene, the negativity, increasing kind of pervasive sense of sadness, uh, inability to focus. They come into your pharmacy, that repeatedly they can't remember why they're there. They're just for someone who's been well put together and on point, suddenly they're distracted and disheveled. All of those kinds of things. Or if in a formerly happy person, they're sad and morose. Just some pointers. You may consider having a conversation with them to ask, hey, just something as simple as, I'm concerned about you. What's going on? If you care to share, and I'm here if you want to talk. Uh, so just the hygiene. These are just some things you might think about as far as the look, the feel, perhaps even the smell if they haven't had a bath in a while. And sometimes it may not be that they haven't wanted to. To attend to personal hygiene. Sometimes they may have been evicted from their apartment, and suddenly they're homeless, and they're living in a car, and or living under a bridge, and they don't have any place else to go. Uh, but if you have that conversation with them, perhaps local resources that you can get them connected with, where they can at least have a place to lie their head at night, perhaps get a meal. Those kinds of things are important. And behaviors, as I mentioned, not so much in pharmacies, but with your professional colleagues, uh, things that might indicate that they're not focused, maybe using negative coping strategies like showing up late for appointments, canceling appointments, uh, the odd or erratic behaviors, withdrawing from things that family engagements, things that they formerly would have been engaged in, or even making comments about threatening to harm themselves, or perhaps family members, even in a joking fashion, because these aren't things to joke about, or signs and symptoms that they might be misusing drugs or alcohol. Just more of the same. Leading up to things that might, leading up to, if an intervention is not introduced, it may lead to a hospitalization, a suicide attempt, because at a crisis level, people are feeling trapped. They're feeling that there's no way out other than an attempt to take their own life. Uh, and those thoughts of self-harm, hopelessness, delusional thinking, hallucinations, that's really can be associated with not just schizophrenia and bipolar disorder, but when you're just so depressed, those the delusional thoughts that this is the only way out can really take over an individual's thinking. Suicidal ideation has been characterized as, you're in this deep dark hole, and you're so deep in this dark hole that you can't see that there's a way out. And so it's very important that a colleague or a peer intervene and help them understand it. Yes, there is a way out, outside of taking their own life, but you have to be able to listen non-judgmentally, um, and make sure that you give the individual some feedback, a head nod, or or I see, I hear you, uh, or what I think I hear you saying is, and repeat that back to them. Let them know that you're listening. That's very important. And then but you don't want to interrupt the person and shut them down, because as I said earlier, that talking catharsis is very important to allow them to just get this out there, because that can be in and of itself can be therapeutic. But restating at some point, restating what the person has said, and summarizing your understanding, that's kind of your teach back method for them, right? I mean, you're kind of telling them that you understand what they're telling you. Uh, your body language is so important. Uh, uh, don't stare. Make appropriate eye contact. If you can sit at eye level with the person, that's great. You know, the way pharmacies are constructed, a lot of times the pharmacist is up on a platform, and so you're looking down at the person. But hopefully, you're in an area where you're in an office where you can have a confidential conversation of this nature, and you can sit at eye level, and hopefully you're not going to sit with your arms crossed, which is a kind of a negative body posture that says you're not listening, and you're not fidgeting, because that says that you're nervous, you're not receptive to what the individual is saying. Just so be mindful of those things, because I'm a fidgeter and I'm an arm crosser, and it doesn't, in my mind, it doesn't have anything to do with my receptivity or my anxiety. That's just I'm a fidgeter, right? And so I just try to will myself to not do those things that I normally do when I'm having a conversation like that. Uh, but you try to give them reassurance and information, hope but not false hope. Just to let them know that you'll be there for them. Uh, Give them practical help, credible information, and let them know that you're there for conversations when they need to talk. Uh, and so it's really important to set realistic expectations, but not to make promises you can't keep, or offer false assurances that, you know, we can get this problem fixed overnight, kind of thing. Because a lot of problems with mental illness can't most problems with mental illness can't be fixed overnight. Um, and don't you know, the last bullet on the right here is really important. You can't you know, don't try to engage in conversation that suggests you don't believe what they're saying, or a conversation that's belittling to the individual. That this is not the time or the place for that. Uh, so, and if the person is not willing to engage in conversation, that's fine. You've planted the seed. Um, you speak slowly, and in short sentences, maybe repeat yourself. Allow plenty of time for the individual to process, because they may be in a crisis, and they're plowing through a lot of information on their own. So give them some time. Don't. It's okay to have dead airspace. Um, just give them time. It's okay for there to be a pause. And uh, if you know uh, the change cycle, sometimes people are in the pre-contemplation phase, and so they may come back to you later and say, hey, you know, I've thought about what you told me, and I think you're right. Do you have time to talk more about it today? And so that, you know, they may come back to you. A couple of words about suicidal thought, and we're running close on time. I did want to say that people who are talking about death, dying, or suicide, uh, it's perfectly okay, and actually recommended to sit down and have a conversation with them. Having that conversation with them is not going to increase their risk for suicide. As a matter of fact, it does the direct opposite. It decreases the risk for suicide. Uh, you can always refer them to the National Suicide Crisis Line, which, as of July 2023, that is a national crisis line for suicide prevention, just like 911. Uh, and you can get them connected to that line if you feel someone is actively suicidal, meaning they have gathered the means, they have a plan, and they're ready to act. You need to be calling the local authorities, if you have a mental health crisis stabilization team that can come out, or just 911 for the EMTs to come out. You don't need to leave that person unattended. But if you get the sense that the person is actively suicidal, and you directly ask the question, are you thinking about killing yourself? Are you thinking about suicide? It's not the time to beat around the bush and ask, are you thinking about harming yourself? Because that can mean harming yourself can mean a lot of different things. You just need to be very direct. So if the answer is yes, they've thought about killing themselves, you ask about, do they have the means gathered? Do they have a plan? Is there a date? That are they ready to go? And if the answer to all these questions are yes, then you need to get them connected to 911 or the local mental health crisis response team immediately. Do not leave them unattended. And if the answer is no, they're just having a tough running into a rough patch. You need to make sure that uh, you're encouraging appropriate professional help. Have you talked to a professional about this? Well, I happen to know somebody. I can get you connected to them. You need to see them as quickly as possible, because it's important that they get connected to a therapist or at minimum a primary care doc to get a complete evaluation going. Uh, and just be confident, just be cool. This is not something you do every day, but you can make the difference. And in somebody's life, no kidding, and it happens every day. Um, and if they don't want help, just remain polite and just let them know that the door is open. As I said, some people remain in the pre-contemplation stage for a time. They may come back to you. All you can do is all you can do. And just to kind of wrap up, just remember, as far as effective communication skills, and this works for everybody, not just persons with mental illness, substance use disorder. Person first language, appropriate body language, focused, open-ended questions. If you To help you know what questions to ask, if you can Google PHQ-9, which is depression, the patient rated depression rating scale, and the GAD-7, which is the patient rated anxiety scale, those kinds of questions, if you can kind of move those into your conversation, uh, that can really help you. You don't have to ask them in the same order. You don't have to ask them in any order, but just know that's kind of the conversational tone you need to get at, not necessarily the first question or the last question, but somewhere in the conversation, you need to get the kind of the answers to those kinds of questions, and just employ active listening skills. Most of these people are people that are coming to your pharmacy. And so hopefully you already have some sort of therapeutic alliance, but empathy goes a long way. If you've taken motivational interviewing, uh, skills training, understanding where the person is, what motivates them, and try to bring along the current situation with their where they are conceptually, and tie the two together in a symbiotic way to help them move forward. It's for an older individual, making sure they live to see their grandchildren graduate from high school, whatever it takes. Uh, but the more you know about an individual and who they are, what makes them tick, it's going to help you be able to grab onto something that can help you work with them to get where you think they need to go. And then lastly, make sure they understand what you're telling them with using the teach back method. Recovery is where we want our people to be, just getting to a place where they can reach their full potential, and lead their best life. All of this is rolled up into the key factors of the recovery: their physical health, having the support of their home and family, having a purpose for living, being part of a greater community. So the things we talked about, you can see if you remove any one of those from their life, that's a negative risk factor for a full recovery. So you can see how stigma would be a negative risk factor for being active in any of these key factors for recovery, because at the end of the day, we're trying to do the best we can to help everybody live their best life safely and with the best outcomes possible. With the same thing you would wish for anybody in your family or your extended healthcare family. If you're interested and want to pursue it, Here's how you can find mental health first aid training locally. You go to www.mentalhealthfirstaid.org, and on that website, you will find take a course and find a course, and there's a lookup window. And from there, you would put in your date range and your location, like by city, state, zip code, and distance. If you are patient, oftentimes you can find a course that might be grant funded, and you can either get it for free or for a nominal fee. I think the cost of the manuals is up to like 25 bucks now. So you may have to pay 25 bucks at minimum. But oftentimes the facilitator cost is underwritten, and sometimes the manual as well is underwritten by grants. If you're willing to be patient and wait a little while till one of those opportunities becomes available. I'm currently working with a group in Southern California who was funded by a SAMHSA grant, and they are training community pharmacists and pharmacy students in Southern California at no cost through the SAMHSA grant for regard with mental health first aid training. So those kinds of opportunities are available here on the East Coast as well. So if you'll just look for them. So I hope that you found this useful, and I thank you for your listening. And my contact information is here. If you would care to follow up. And if you want a copy of the slides, send me an email, and I'm happy to share it with you. So thank you very much for your participation today. Thank you.